Hello, everyone. I am Simona Sacco, Professor of Neurology at the University of L'Aquila in Italy and second Vice President of the European Headache Federation. And I'm pleased to welcome you to this final module of the Touch Clinical Perspective activity. I hope you enjoyed the other modules of this activity. I really enjoyed them a lot. And I'm now with you to briefly summarize what we have learned with this activity, and also to provide a brief overview of some new contents presented at the recent International Headache Conference and the contents recently published in international journals. So let's start. So we had several modules dealing with different topics and with different speakers. We learned from Elena Ruiz de la Torres, patient representative, what does it mean to live with migraine. Migraine is, as you all know, a burdensome condition that can really impair the quality of life of patients. She gave really good advices, suggesting to refer to expert care, to refer to doctors who have the knowledge of the migraine field, so to headache centers, because it's very important to have a right diagnosis and the right treatment. And she also shared her personal experience on how new migraine treatments, such as those acting on the CGRP, can improve the quality of life and can be really a game changer in this field. Then we had one other module by Professor Shibata from Japan. He shared his personal experience using monoclonal antibodies in real life in Japan. This is really something important because patients from Asia were less represented in clinical trials. Real-life data from Japan confirm that monoclonal antibodies are effective in reducing monthly migraine days, but they also are very effective in improving quality of life and reducing disability. And the safety of the monoclonal antibodies is not different in Asian patients as compared to patients included in randomized clinical trials or patients included in real-life studies performed in Europe or in the US. We also had a module from Professor Lamp describing the European Headache Federation guidelines on the use of monoclonal antibodies for migraine prevention. And I really encourage you to read this paper and have a more in-depth look at the content. The document provides really valuable practical advice on how to use monoclonal antibodies in daily clinical care in your headache centers. You will find advices on duration of treatment, on the use of concomitant treatments, on contraindications, on switching from one treatment to another, and on the use of monoclonal antibodies in patients who have medication overuse. So a really useful document to read. And lastly, we had the module by Dr. Parikh, sharing again her experience on the use of monoclonal antibodies and focusing in particular on the features, on the characteristics to consider when selecting a preventive treatment for a patient who has migraine and who is in need of migraine prevention. She reminded us how is important to have a look at the patient comorbidities, because they can be really important to select the right treatment, especially when we consider conventional oral migraine preventive agents. She also suggested that it's important to have a conversation with the patient to understand also the special needs of each single patient, and to discuss the schedule of the treatment and also potential side effects in order to select the best treatment for each patient. And a reminder from all the speakers in the different modules is on the migraine diary, and on how much it is important to use a migraine diary in order to assess the real burden of the disease and to track the changes that occur after starting a migraine preventative. In the last few months, there were a number of studies published giving us more insight on the use of monoclonal antibodies for migraine prevention. I've selected just two of them that provide information on two very important points. One is a study performed in the UK and in Italy. We contributed to this study on switching from one monoclonal antibody to another one. Patients treated with erenumab, a monoclonal antibody targeting the CGRP receptor, and who were not responder to erenumab were switched to a different monoclonal antibody targeting the receptor. Results were interesting since the study showed that those patients who were not responders to the first monoclonal antibody in 1/3 of cases had a positive response to the second monoclonal antibodies that with a slightly different mechanism of action. So the key message is that the switching may be an option for some patients. It's important to remind that this is observational data from real life, so we cannot exclude the placebo effect, we cannot exclude the spontaneous fluctuations of the disease, but nevertheless, switching may represent a successful option, at least for some patients. One other study, it's a multi-center study performed in Italy, including more than 200 patients. In Italy, per regulation by our national agency, we are forced to pause the treatment with the monoclonal antibody, any monoclonal antibody, after 1 year. And this study provided data results on what happens to patients who stop the treatment and then resume the treatment during the 2nd year. And very interesting, and I want to say also very reassuring, this study confirmed that the monoclonal antibodies is effective even when resumed after a pause. And this is a very useful information from our clinical practice. There were several papers, several abstracts reporting findings from the CAMEO study. CAMEO is a really huge study performed in the US, in Canada, and in Europe, addressing the burden of migraine in real life. And the study provides figures that really represent what does it mean for patients to have migraine, the stigma of the disease, the cognitive impairment, and the impact on work and life. And I suggest to have a read to this study and to use them when talking with the stakeholders and when giving presentation to explain the burden of the disease. Then one other very interesting study was a very large study in nearly 5,000 patients performed in Europe, a multi-center study addressing efficacy and tolerability of monoclonal antibodies after 6 months of treatment. This study reported that monoclonal antibodies are highly effective. Nearly 60% of patients are at least 50% responders. More than 25% of patients are at least 75 responders, and that the tolerability profile of those drugs is really excellent. So in real life, the efficacy and the tolerability of those drugs is confirmed, and probably is even better than what is expected by looking only at randomized clinical trials. During the conference, also interesting data on antibodies which were presented. There was an observational study performed in the UK, observing what happens if patients treated with erenumab, so a monoclonal antibody acting on the CGRP receptor, switch to a second antibody acting on the ligand, so on CGRP itself. And this study reported that there was an overall responder rate of 58%. So switching from one antibody acting on the receptor to a second antibody acting on the ligand, it's an option for some patient. The same study explored also what happens when in the non-responders there was a switch to a third monoclonal antibody. So a monoclonal antibody again acting on the ligand. And in this case, there were no significant benefit. And so while switching between two monoclonal antibodies with a different mechanism of action seems an option, switching from two monoclonal antibodies with the same mechanism of action does not appear to be a good option. Again, those are the observational studies, and so prone to some bias, and that are worth to be addressed in randomized studies. Real-world data on CGRP monoclonal antibodies provide a strong support on efficacy and tolerability data from those drugs. In randomized clinical trials, patients naive to treatment or with a limited number of treatment failures were included. In real-life settings, many patients receiving monoclonal antibodies are the difficult to treat patients. So those patients who had failed several, if not all, among the available preventive options. And so real-life data confirm that even in this difficult to treat population, monoclonal antibodies are really effective. One other data that comes out from real-life data studies is treatment persistence. This was really a big problem with the oral drugs because we know very well that a lot of patients stopped the migraine preventive treatments because poor tolerability or the efficacy that was not as high as expected. This does not really happen with those new drugs, and so the persistence in the use and the adherence to treatment is really one point of strength of those new drugs that really comes out from observational data. Observational data also shows that use in the long term is associated with a persistence in the effect, and this is also again a novelty and a big advantage of those new drugs, because with the oral agents we were used to see deterioration of response over time. And lastly, there are observational data showing that switching from one monoclonal antibody to another, especially when we switch from one mechanism of action to another one, is a viable option for some patients.